Hi everybody, we are Ofer Sarne and Kobi Landsberg. We want to thank Dental XP and Dr. Morris Salama for inviting us to be part of this special project.
Kobe and me treat many patients together. We certainly recognize the advantages of working together as a team. Not only planning a case, but also when performing it, and certainly when analyzing the treatment outcome in detail.
We believe that our patients may only benefit from being treated by a team that encourages thinking, performing, and finding solutions, sometimes out of the box. Our presentation today will discuss about the importance of sequencing of periodontal regeneration and orthodontic treatment for long-term aesthetic results. Sequencing means what comes first, what should be placed first, what should be done first. We know that sequencing matters. In genetics, for example, if the green amino acid comes before the red amino acid, this person would have a blue eye. But if we change the order of these two acids, he may get a brown eye. In preparing a good dessert, sequencing does matter. We can pour the coffee first and place the ice cream second. Or place the ice cream first and pour the coffee second. Same ingredients, different sequencing, and what a difference. Here you have iced coffee, and here you have affogato. Can you compare?
And sure enough, in dentistry, sequencing matters. And when it comes to perio and ortho, do we have to start with periodontal regeneration and then align the teeth? Or maybe tooth alignment should be the first level in the pyramid? Well, we think that periodontal regeneration in dentitions involved with advanced periodontitis should be done first. And we will share with you our clinical assumptions and experience through the demonstration of this specific case. We will focus on the front upper sextant. You can see the spacing, the vertical and buccal migration of these incisor teeth, and of course advanced bone loss on the right lateral incisor. Now, what do we know about situations like this? What does the literature tells us?
If we do ortho first, that is immediately after non-surgical root planning, and we close interdental spaces, some researchers will tell us that narrowing the defect will increase the amount of walls around the defect, and this will increase the regeneration potential. Others say that patients will simply like it very much when you align their teeth quickly, but actually by doing it, we may cause deterioration of the defect. And why is that? Well, as Lovdal and Verhaag showed us, amongst many others, in deep pockets, meaning pockets deeper than 5 mm, it is difficult and unpredictable to remove plaque, calculus, and root toxins and to ensure effective degranulation. Verhaag also showed us that around the plaque or calculus there is a radius of infection of about 1 to 3 mm. This means that the defect may be enlarged and become deeper. And as Tal showed us 30 years ago, if the distance between the roots becomes less than 3 mm, the supporting bone of the neighboring tooth will disappear and we will get a horizontal bony defect, which is our nightmare because you can't grow much or any bone in a horizontal bony defect. And if the bony crest will stay here, the papilla will never fill up the embrasure no matter what we do. Let's see for a few seconds a clinical case that will demonstrate what we might get when we do ortho before perio. Well, this young girl came to the clinic complaining of bleeding gums in this area. She said she had ortho treatment for closing spaces between the front teeth, and she went through deep scaling and root planning as initial perio preparation, meaning no surgery was done before orthodontic therapy. We believe this is wrong because now, as we want to save those 2 teeth, we know we will never be able to get the full papilla again. So this is what we could do. We opened up the area and kept the full papillae and debrided the defect. Used enamel protein derivatives, filled the defect with deproteinized bovine bone, and sutured. We ended up with a healthy periodontium, but the papilla was lost. Did we expect the full papilla to regenerate? I don't believe so. So here we are at the beginning, and here, yes, we saved those teeth for the girl, and we shifted the contact point apically with a composite, which is of course a compromise, but we felt this case should have been treated differently, meaning perio-regeneration should be done prior to orthodontic movement. When our colleague Dr. Rafi Romano and myself, back in 1996, received this other case, we knew we should not start with ortho, simply because there was a periodontal abscess, and if we didn't start right away with surgery, we might have lost the left central incisor. We actually didn't know that we're going to gain much more than just saving the tooth. So we decided to treat the defect first. We grafted the defect with demineralized freeze-dried bone and closed the flaps primarily. This becomes easier when the teeth had not been approximated yet and the interdental space is large. And after 5 weeks of healing, we started with ortho. This is actually the end of ortho. And we got this nice result. You can see that the tooth is safe now. The papilla is nice, and we got a bonus. By tooth approximation, intrusion, and some retraction, we got the gingival margins back to the CJ. Since then, quite a few articles had been published which discussed the advantages of doing the surgery first. It is interesting to see that today there is no consensus on the timing, meaning how long should we wait before we can start with moving the teeth. Some suggest to wait 6 months or even 1 year for complete tissue maturation. They would prefer the tissues to heal completely before we move the teeth. They assume that in early wounds there are probably too many bone-resorbing cells that may be activated to damage the root, like you see in this histology. But nobody actually showed that this is really happening, except in few case reports where biologically incompatible materials that elicited foreign body reaction were used. Now, those who advocate early tooth movement, like us, realize first that tooth movement will take less time, and even more important, we think actually observe that the immature, the still unorganized interproximal soft tissues will react better and actually move to where we want them to move before they mature and bound to the bone and the teeth. Our experience to date is limited to less than 10 cases, but from what we saw in our cases is that when we initiated ortho only 5 to 6 weeks post-surgery, we could indeed get nice results.
So let's go back to our case. Based on our experience, we suggested the patient to treat those lesions surgically and as soon as possible. But she declined surgery at first, so we had to treat her non-surgically. Well, immediately after scaling and root planing as initial therapy, We placed the brackets and started with tooth alignment. We went from here to there, but as we expected, we couldn't really control inflammation, and the deep pocket was still present and bleeding, the papilla was still missing, and the gingiva still recessed. So at this point, we were able to convince our patient to undergo periodontal surgery.
We elevated wide full thickness labial and palatal flaps. Both had vertical releasing incisions. We actually used the papilla preservation technique as published by Takei, so we didn't lose any tissue, and then we debrided the defect thoroughly. We applied enamel protein derivatives on the root surfaces and placed the bone substitute. Combining those two regenerative materials is well supported by the literature. We also released the labial flap to be able to advance the flap and to try cover the root of the right lateral incisor. And of course, we made sure we could effectively approximate the flaps and suture without tension so that we could isolate and stabilize the bone graft.
After 5 weeks, you can see that we have been able to gain some root coverage. However, this important papilla didn't fill up the embrasure. Is there a way to regenerate this papilla? Since the crowns had already been approximated, we supposedly lost the opportunity to push the interproximal tissues and to grow the papilla. So we thought the only way to do this is perhaps by approximating the roots. This means we are going to tip the roots towards each other, and we will have to tilt the crowns too. And indeed, we were able to capture the papilla this way, and together with some intrusion, we were able to gain root coverage. This took 7 months. But here's the price we had to pay. First, we end up with a measly tilted right central. And second, we got minimal apical root resorption of the lateral incisor. This resorption, by the way, does not continue once we stop the tipping movement. You can see here that our referring dentist did not wait till the very end of treatment and added a composite filling on the right central tooth. After we completed ortho, we felt there was much improvement of function and aesthetics, and we splinted the teeth with braided orthodontic wire. And when we look at the lateral tooth, we can see the solidification of the lamina dura and the interproximal crestal bone. 1 year from the end of treatment, the patient could demonstrate a happy smile.
You can appreciate the remarkable improvement of the position of the lateral incisor and the contour and health of the gingiva. To achieve this result, we feel it would be a mistake to leave surgery to the end. Schematically, we can summarize what we might gain through the whole process, going from regeneration till the end of tooth alignment. We can easily and predictably remove all calculus and necrotic cementum. We can also penetrate the defect walls to recruit bone-forming cells to the wound, exactly as we do in treating ridge defects. And we can enhance bone regeneration, gain higher papilla, and even better root coverage. And to complete the case, I would like briefly to address the other lateral tooth, which had this shallow recession but still had some negative impact on the aesthetics. The problem here is that we don't have the full amount of papilla and bone as we would like to have. But as was discussed nicely by Zucchelli, we may succeed to cover roots of such teeth if we increase the width of the gingiva, if we change the biotype. And we do this by using a thin dense connective tissue in a bilaminar procedure, meaning this connective tissue graft becomes fully covered by the coronally advanced flap, and we use here mainly 7/0 sutures. And here the tissues at 2 weeks. We can assume there is not going to be much of a scar tissue on those release incisions. And at 4 weeks. So also the left lateral incisor looks much better now. And at 2 years after initiation of therapy and 2 months post-root coverage procedure, the smile had improved aesthetically. Here, 3 years after end of active treatment, we can see that the gingiva looks healthy and there are no changes in tooth and gingiva position. And here, after 5 years, it looks as if there was a minor gingival recession on the right central. However, the overall result had been maintained long term. To summarize the clinical concepts applied in our case. On the right side, where we diagnosed both deep periodontal defect and tooth migration, we advocate performing perio regeneration first and tooth alignment second. However, when we just need to cover an exposed root having an intact or almost intact periodontium around it, we first align it and only then we do the root coverage procedure. That is, if we want to achieve long-term aesthetic and functional results. So to get from malaligned and periodontally involved teeth to nicely aligned and well-supported teeth with healthy periodontium, we need to perform the necessary procedures well and in the right sequence. Exactly as with our desserts of the day, we can do each procedure or each ingredient good, and this will make us efficient. But if we do the procedures good and in the right sequence, we become effective. So thank you all for listening to us, and please join us for a good dessert.
Made in the right sequence.
Goodbye and shalom from Tel Aviv.
Bye bye.